Hi, and welcome. We conducted a systematic review and meta-analysis to study the use of intrathecal baclofen to treat spasticity in spinal cord injury patients. My name is Julie Stoll, and my research partner is Philip Springer. Our research advisor and professor at Georgia State University is Dr. Brad Farrell. Philip and I are part of the Doctor of Physical Therapy class of 2022 at Georgia State University. Our contact information is located at the top right of our poster. After spinal cord injury, or SCI, many patients have spasticity that can greatly affect their activities of daily living, function, and mobility. One of the most common treatments for spasticity is baclofen, which promotes neural inhibition. Baclofen can be administered orally or intrathecally. The latter method has reduced drug side effects as compared to oral administration. The goal of our study was to determine if intrathecal baclofen, or ITB, is effective at controlling spasticity in spinal cord injury patients.
Using PubMed, Spinal, Cochrane, and Embase, we were able to find 722 studies that met our inclusion and exclusion criteria. For a study to be included, the spasticity of the subject must have been caused by spinal cord injury. Intrathecal baclofen from a pump was used to treat the subject's spasticity, and the Ashford scale or modified Ashford scale were used to measure spasticity. If any other cause of spasticity was identified or any other outcome was used to measure spasticity, the study was excluded. Additionally, animal studies, case studies, and studies without an English translation were excluded. Ultimately, we found 16 studies that met our criteria with a total of 238 subjects that were treated with intrathecal baclofen. From each study, we extracted the mean spasticity measurement and standard deviations before and after administration of intrathecal baclofen, and we used comprehensive meta-analysis software to analyze this data. To calculate our effect size, we used Hedges G as it is the primary outcome measure for a meta-analysis. Using the fixed effect model, we calculated Hedges G to be 2.655, indicating an extremely large experimental effect. Spasticity scores decreased from 3.68 plus or minus 0.79 before implantation to 1.49 plus or minus 0.71 after implantation. Using this funnel plot, we have identified a study that may contain publication bias. Next, we plan to use Duval and Tweedy's trim and fill to determine how this publication has affected the overall effect size.
In conclusion, our analyses support the use of ITB and indicate that it can be beneficial for many years. However, higher doses are typically needed as drug tolerance develops. Lastly, to optimize efficiency of spasticity management, it may be best to incorporate physical therapy to gain the greatest outcomes in spasticity reduction. ITB can improve the lives of patients by reducing pain and increasing function, and as physical therapists, this information is helpful when communicating with physicians to determine a method of management and can be beneficial knowledge in developing a plan of care for this patient population. COVID most likely affected spasticity treatment plan development by delaying surgeries and reducing in-person appointments to assess effectiveness and for infection at the surgical site. Additionally, in-person research on the utilization of PT for SCI patients with ITB may be delayed due to safety concerns.